السلام عليكم ورحمة الله وبركاته. أنا الدكتور محمد نزال، مدير مشروع إيراسمس بلس، مشروع علوم التأهيل السريري. I'm Dr. Mohammed Nazal, the coordinator of Just TRS Master Program, which is a grant co-funded by the Erasmus Plus program of the European Union. We are honored today to have this webinar series to support therapists in Jordan and the Arab world. And this is our second presentation, second webinar. We are so honored to have you here. Our webinar today is Brachial Plexus Injury, a Multidisciplinary View. This is, again, a part of the Clinical Rehabilitation Sciences Program, which is a grant from the European Union in collaboration with Oxford Brookes University in UK, ESSA University in Portugal, University of Jordan in Jordan, the Hashemite University in Jordan, and the Hacettepe University in Ankara. We are honored to have Mrs. Rawanda Hamdan. She's a teacher assistant of physical therapy in the Department of Rehabilitation Sciences, Faculty of Applied Medical Sciences in Jordan. And this is her email. And I'm going to give now the time for Mrs. Rawanda.
Good evening, everyone. Thank you for participating today. Today, we're going to talk about brachial plexus injury, the definition and classifications. We're going to talk about brachial plexus birth pulses and definitions and types, how to assess them both, and the rehabilitation used. We are going to discuss more about CIMT, post-operative physical therapy program for latissimus dorsi and teres major tendon transfer into rotator cuffs, and virtual reality. Okay, so what is a brachial plexus injury? A brachial plexus injury is a relatively frequent condition leading to a complex functional impairment of the upper limb and disability. It can be caused by numerous causes, such as traumatic accidents, which include traction forces, a wound, or compression of the plexus on the hard surfaces of any neighboring structures, such as ribs, vertebral bodies, or even muscles. A second cause is the tumors or inflammatory diseases, or it could be during birth, which gives rise to brachial plexus birth palsy. The classification of brachial plexus injury is it can differ from adults and children because of the sites of the lesions. In adults, it's based on the lesion sites, and they are divided into supraclavicular parts, retroclavicular part, and infraclavicular part. As everyone knows, we have in the brachial plexus, we have roots, trunks, divisions, cords, and finally the branches. Children lesions are according to are on the basis of roots involved. For the adult lesions, the first type is the supraclavicular injuries, which account for 75% of the cases. It involves roots and or trunks. There is a true avulsion of the subclavian artery that can be associated. The mechanism of injury is a trauma that produces violent head and neck movement away of the ipsilateral shoulder. We shall have a short video that describes the supraclavicular nerve and the involvement of the muscles. Okay, so the supraclavicular lesion had 3 nerves involved: the dorsal scapular nerve, suprascapular nerve, and the long thoracic nerve. The dorsal scapular nerve innervates the levator scapular muscles, rhomboid minor, and rhomboid major muscles. Thus, if these muscles became paralyzed, the scapula will not be retractable. and the shoulder will tilt inferiorly and forward. The second nerve is the suprascapular nerve, which innervates the supraspinatus muscles and the infraspinatus muscle. The suprascapular nerve passes under the transverse scapular ligament at the suprascapular notch. The transverse scapular artery runs above the transverse scapular ligament. The artery and nerve join and pass the spinoglenoid notch under the inferior scapular ligament. The suprascapular nerve gives branches to the supraspinatus and the branches of the infraspinatus muscles. Thus, a nerve compression at the suprascapular notch affects the supraspinatus and infraspinatus and decrease in abduction and loss of the external rotation of the shoulder. A nerve compression at the spinoglenoid notch affects only the infraspinatus and losing external rotation of the shoulder. The spinoglenoid notch compression can occur in volleyball players and is usually associated with cysts, ganglia, or even slap tears. The infraspinatus muscle is the primary external rotator of the shoulder, as we know. The third nerve is the long thoracic nerve. It supplies the serratus anterior muscle. If paralyzed, the serratus anterior muscle will cause a medial winging of the scapula. A medial winging of the scapula is due to injury of the thoracic nerve and the deficit of serratus anterior. Okay. The second two types is the retroclavicular injuries, which are the least common, and it involves the divisions of the brachial plexus. Vascular damage is often present. The third type is the infraclavicular injuries. They involve the distal branches of the brachial plexus. Vascular damage is associated only with 30% of the cases. The mechanism of injury includes a violent injury to the shoulder girdle, which is an abduction trauma, and anterior shoulder dislocations. Okay. A brachial plexus birth palsy involves an injury to any nerve of the brachial plexus during birth. The most common presentation is Erb's palsy, which accounts for 50 to 60% of the cases, followed by the more severe upper plexus. Klumpke's is a lower plexus palsy, which is rare. It only accounts for 0.6% of the cases. The lesions can be classified as preganglionic or postganglionic. In preganglionic lesions, the nerve injured proximally, for example, the root avulsions. This is a more difficult to hear and to repair with worse outcomes. The postganglionic lesions, however, they are nerve injured to the distal of the root ganglion. According to Sutherland classification, nerve injuries is classified based on the nerve structure damaged. There are three types. The first one is neuropraxia, which is a stretch injury, but with an intact nerve continuity. This gives a good spontaneous recovery. The second type is the axonotmesis, which is an axonal injury with an intact nerve sheath. This is why it is a variable spontaneous recovery. The third time, which is the worst, which is neurotemesis, it's a complete nerve rupture. Neither the axon nor the sheaths are intact, and this gives a very poor prognosis to spontaneous recovery. The types of brachial plexus birth palsies. The first one is the upper trunk, which is Erb Duchenne or Erb's palsy, and it is only disruption to the input from C5 and C6. Thus, it affects the shoulder and the elbow. The upper plexus palsy involves the roots from C5, C6, and C7, so it reaches a more distal deficits. The lower plexus palsies involve the C8 and T1, so it affects mainly in the hand. A palmar plexus injury is the most severe one, which affects from C5 up to T1, and it has a loss of all functions of the upper extremity. How to assess a brachial plexus injury? The first and the most important examination is the clinical evaluation. Early diagnosis of brachial plexus injury is the most important, both in newborns and in adults, since secondary damages could lead to disability and functional impairment. In the acute phases, clinical history is very useful in identification the traumatic mechanism of injury in adult patients. In addition, the diagnosis could be acute pain, skin bruising, and focal ecchymosis. Neurological clinical examination can suggest a general identification of the extent of lesions. That means the area of motor paralysis and sensory loss correlate with the site and extension of the brachial plexus injury. The second way to assess is the instrumental examination. It is important to support the clinical evaluation in adults and children. Recent studies have suggested that in adults, the CT myelography is the gold standard for detecting the site of lesion and the amount of damage. In children, MRI and ultrasound scan is used based on the low compliance of the newborns. As we all know, it is not easy to take control of a newborn and hold him in place. Plus, there's a need to use less invasive techniques. How to assess the brachial plexus birth pulses? First, there's a maternal history, which is the conditions during delivery, pre or post the delivery, or if there's any family-related diseases or problems. Physical examination is very important. We should look for abnormal primitive reflexes, such as motor reflexes and tonic neck reflexes. Erb's palsy, which is, as we said, from C5 and C6 nerve roots, it will include the shoulder adduction and internal rotation plus the elbow extension. So the baby will come with this type of deformity because of weakness of the deltoid, supraposterior rotator cuff, and biceps. The upper plexus palsy, which is C5 to C7, it will have shoulder adduction, internal rotation, and elbow extension, in addition to wrist and finger flexion due to weakness of the wrist and finger extensors. The palmar plexus injuries, which are the most severe ones, they will have a flaccid extremity. Diagnostic imaging can be used. We can use radiographs just to rule out fractures or any other bone problems, CT myography or MRI to determine the root avulsions. Many scoring systems can be used for the brachial plexus birth pulses, such as Toronto Test Score, Active Movement Scale, and Modified Mallet System, which is the most commonly used. Toronto Test Score is a scale from 0 to 7, which relies mainly on the muscle contraction and the muscle movement. 0 means nil, which is no contraction at all, and 7, he will have full motion against gravity. The active movement scale is similar. It's from 0 to 5, and 0 will mean no contraction, 5 will have a normal power. The modified Mallet classification is a bit different because it uses the function as a classification criteria. There are 5 grades from 1 up to 5, okay, for the different motions. Let's take, for example, there's a hand to spine. If it is not testable, you will just write not testable. Grade 1 means there's no function. Grade 2, it means he tried, but it is not possible. Grade 3 means he reached the S1. Grade 4, he reached the T12, and grade 5 is normal. Okay. Rehabilitation of the brachial plexus injury. Adult patients require early and prolonged rehabilitation treatment. There could be limitation of range of motion, muscular contractions, joint stiffness, and development of secondary deformities. That's why physiotherapists and physicians' role is to provide appropriate information to the patient to increase the compliance to treatment and thus achieve the goals. Occupational therapists, on the other hand, will improve the patient's functional abilities by stimulating the workplace setting, adaptation, and the manufacturing of orthoses. The goals of rehabilitation are prevention of muscle atrophy. This can be done by passive muscle stretching and the use of electrical stimulation. Prevention and restraint of secondary deformities. This can be achieved by range of motion exercises and the use of orthoses to maintain these range of motions. Pain suppression, either by pharmacotherapy or even using the TENS. The recovery of somatosensory deficits. This is gained by sensory re-education. Sensory re-education is very important and can be achieved by cognitive learning techniques, vibration and weight bearing to the extremity, tactile stimulation such as brushing, or even video-tactile by using mirror therapy. 5. Developmental disregard restraint, which is the use of the stronger arm and neglecting the weaker arm. This can be achieved by using the CIMT, which we will discuss in a moment. 6 is the post-operative care. In the rehabilitation of brachial plexus burst pulses, now we'll discuss the CIMT, which is a case report. CIMT is constraint-induced movement therapy. As we said, it is a constraint of the non-affected extremity associated with intensive task related to training of the affected extremity. The target is to improve the upper extremity function in individuals with neurological dysfunction. Constraint is involved in 90% of the working hours for 2 to 3 weeks. The case report is a female child with right herbs palsy after a forceps delivery. Received a PT sessions twice a week until the age of 2, and then she reached a plateau. She demonstrated an ability to use the affected upper extremity into reaching and holding objects during the sessions, but her mother complained that she demonstrated little spontaneous use of her arm at home. The family was invited to take part of a course of treatment based on the principles of the CIMT. Based on the limitations in the activities at home and the difficulties in attending the daily sessions, a home-based intervention was designed with the family. The child was able to actively moving the shoulder, wrist, and fingers, but not in full range of motion. For example, she did not have an active elbow movement. She was capable of raising the arm with shoulder abduction and trunk extension and lateral flexion. She could grasp small objects, but it slips off her hand. She had difficulties in the following activities of daily living: combing her hair, detangling her hair, donning the shirts, sweaters, or even dresses without a front opening, donning trousers without an elastic waistband. The intervention protocol was daily training session lasted for 30 minutes. During all sessions, movement of the non-affected arm was restricted by dressing the child a jumper, which is such as like a jacket, closing the opening of the left sleeve and tying it to the child's back. A schedule of 3 tasks, each to be participated for 10 minutes, every day was defined for each 2-week period. So after 2 weeks, the tasks are changed, but it remained for 30 minutes. The tasks were chosen based on the child's age and interest and focused on the abilities needed for play, self-care, and school activities. The task difficulty was increased progressively. For example, we have these recommended tasks. Of course, the child had 7 scheduled. Each schedule is for 2 weeks, and each schedule contained 3 tasks. For example, in schedule number 1, she had to do finger painting, tear a paper towels with single thickness, make something with a Play-Doh. In schedule number 4, she was asked to spread a moisturizing cream on a mother's body or even a doll. She was asked to pick up and eat biscuits, reach and grasp the mother's clown nose. In the last schedule, she was asked to assemble a foam puzzle, remove small puzzle pieces stuck on a Velcro to a background, and pick up and eat breakfast cereal. All schedules contain description of the tasks in simple language and how to increase the difficulty. At the end of the session, the mother rated the child's performance. We have here a task, which is in schedule number 4, spread moisturizing cream on mother's body. The task takes 10 minutes, and the description is clear. She should spread the cream on a doll on her mother's body. In the first day, the doll or body part should be positioned at the height of the child's hip. The height is increased later on to increase the difficulty. By the end of the session, the mother gives a rating from good to poor to very good, from Sunday up to Saturday up to 2 weeks. The assessment tools used is the toddler arm use test, which is an observational test, and it contains 21 functional tasks and play activities scored in respect of the functional use of the affected extremity. The task is distributed, and we have some examples in here. The first assessment was conducted before the initiation of the interventions, and subsequent assessment were performed every 2 weeks. And in conclusion, there were interventions. This intervention lasted for 14 weeks, as we said, 7 scheduled changes with 8 assessment sessions. In the assessment tool, there were separate scales used to score. First, the participation of the affected arm, which gave a score from 0 to 2. 0 meant the child did not attempt even to use the arm, and score 2, the child used it to carry out the task, regardless if this task was age-typical or is not. Second is how well, which is a score from 0 to 5. 0 means the child does not use the arm. 5 means the child's ability to use the weaker arm for a task typically for that age. Willingness means from 0 to 3. 0 means the child never even attempted the activity. Score 3 means the child demonstrated no resistance to use the arm and attempted the activity with it. As a result, in participation, at baseline there were similar percentages. After the 5th assessment, there was no 0 scores. In the last assessment, the child scored 2 in 93% of the tasks. How well? There were again similar percentages at baseline. After the 5th, there was again no 0 scores. The first assessment, she did not use or give us, which is a score 0, very poor, a score 1, or poor, a score 2, while 67% of the cases. While in the last assessment, score 3, which is fair, score 4, almost normal, was in 58% of the tasks. In the willingness, from the 5th assessment, there was no 0 scores. In the last assessment, there was no 0 or even 1 scores. A score 2 got 92% of the cases, and score 3, she got 8% of the cases. In conclusion, the results of the study suggest that intervention based on the CIMT principles has potential to promote functional gains in children with the brachial plexus burst palsies. It suggests further investigations regarding the application of CIMT for peripheral nervous system injuries. The second rehabilitation we're discussing is the post-operative physical therapy program 4, latissimus dorsi and teres major tendon transfer to rotator cuff. Half of the cases of brachial plexus burst palsies show spontaneous recovery. Some children are left with significant impairment of the shoulder function, which is weakness in abduction and external rotation due to the impairment of deltoid and rotator cuff. The ultimate purpose of the treatment is to improve and restore the upper extremity function, especially the shoulder. Treatment options differ according to age. In infants, for example, the early microsurgical reconstruction of the plexus is recommended. So, the procedure weight or the surgery is a transferring from latissimus dorsi and teres major tendons into rotator cuff. This is recommended for patients under the age of 7, with the best age being 3 to 4 years. The target is to increase the stabilizing effect of the rotator cuff, which are shoulder external rotation and abduction range of motion. The post-operative physical therapy program is needed for two purposes mainly. First, for the shoulder and surrounding muscles to adapt the new configuration, since these muscles used to do another function and now they are going to perform as rotator cuffs, plus increase the muscle activity level. The TPT program has many phases. The first one is the maximal protection or the acute phase, which is from 0 to 6 weeks post-op. Patient is in a plaster cast for 6 weeks. The cast is to maintain the extremity on shoulder 80 to 90 degree flexion and abduction, 90 degree external rotation, and 90 degree elbow flexion. The forearm is in neutral. The program includes a postural instructions to prevent any deformities, hand squeezing exercises to maintain the grip strength, wrist joint active range of motion, and active resistant range of motion if possible. The second phase, which is the transition phase, the most important one, which is a 7 to 8 weeks post-op. The cast now is removed, but the patient wears a plastic splint for 2 weeks, which replicated the joint positions in the cast splint. And it is designed to prevent the elongation of the transferred muscles, control the pain, and restore the physiological balance between the internal rotation and external rotation. The splint is removed 3 times a day for 1 hour each, so a maximum of 3 hours. The exercises or the PT exercises included a pendulum exercises for the shoulder and circular movement, either clockwise or anti-clockwise. Active assisted range of motion and self-mobilization using a pulley system or wand, only for flexion, abduction, and external rotation. Active range of motion within the available range for all movement except internal rotation and horizontal adduction. Mobilization, active resisted range of motion for elbow, forearm, and wrist. Stretching for the biceps brachii and pronator muscles. Hand squeezing, active shoulder shrug, and scapular retraction, but without resistance. Importantly, there is no passive or stretching for the internal rotation, horizontal adduction, extension in this phase, and no forced passive flexion, abduction, external rotation. The patient has to do it by his own limits, and non-weight bearing to the upper extremity. The third is the splint withdrawal phase, which is from week 9 to 10. The splint is now removed, and it's only worn during sleeping for another 2 weeks. The exercises is performed 3 times a week, the same as before, but we can add mobilizing the elbow joint if the limitation is still present, stretching exercises with the subscapularis and biceps muscles, active assisted range of motion for the shoulder flexion, abduction to 150, and for external rotation. Active resisted extension for elbow extensors, forearm supinators, wrist and hand muscles. Active scapular range of motion in retraction, protraction, upward and downward rotation. Active range of motion within the available range for all movement, again, except for internal rotation and horizontal adduction. We care for the scar tissue management to the surgery site, which by using deep friction massage, cream, gel, or even ointments, and desensitizing exercises around the scar. Again, no passive or stretching for the internal rotation, horizontal adduction, and extension. No forced passive flexion, abduction, external rotation. No shoulder strengthening till this phase with resistant exercises, and no lifting or carrying with the affected arm. The full range of motion phase, which is from week 11 to 12, the exercises continue as previously, but stretching or